Welcome everyone to Dermpath Diagnostics webinar, where we will be discussing MelaNodal Predict, the newest addition to our advanced oncology portfolio. My name is Liz Holland. I am with Medical Affairs in the Oncology franchise at Quest, the parent company of Dermpath Diagnostics. And regarding MelaNodal Predict, it's our newest addition to our portfolio. It's a tissue-based predictive assay that's used to identify melanoma patients who may safely forego a sentinel lymph node biopsy, which is a costly and invasive surgical procedure, with long-term data to support this utility. We are joined by two experts who will discuss MelaNodal Predict, how it fits into the melanoma testing continuum, the body of evidence behind the assay, and the clinical necessity of a predictive test in melanoma. With us here is Dr. Alexander Meves, Professor of Dermatology at Mayo Clinic College of Medicine and Sciences. He is also a cutaneous oncologist at the Mayo Clinic, with a career rooted in both clinical practice and translational research. Educated at Heinrich Heine University Medical School and fellowships at Harvard Medical School and the Max Planck Institute, Dr. Meves has dedicated his work to advancing the understanding of skin cancer. He also has significant contributions to the design and development of the assay that we will be talking about today. We're also joined by Dr. Nousari, who is a dermatopathologist, a practicing clinician, researcher, and prolific author in dermatoimmunology, dermatopathology, and immunofluorescence. In particular, he has conducted significant research in autoimmune blistering diseases, immunosuppressive therapy, connective tissue disorders, and vasculitides. As the current medical director of the Institute for Immunofluorescence, Dr. Nousari provides excellence in immunofluorescence testing, as well as consultation for routine histology for difficult cases of autoimmune and inflammatory skin diseases. So without further ado, thank you both for joining us here to share your expertise on this assay. So we'll start with you, Dr. Meves. Can you talk about the unmet need in clinical practice as it relates to melanoma patients and the patient journey, and how there is a space for this assay?
Yeah, so in fact, I could share some slides with you if you want me to do that.
Sure.
As everybody knows, more recently, there's been a major paradigm shift in how we think about melanoma and how we treat melanoma. It used to be that we would live in this surgery-centric treatment model where basically all we could do to help our patients was surgery. That was our primary way of sort of preventing melanoma metastasis and helping our patients. But then obviously in 2017, 2018, the world changed after these big trials, MSLT2, Keynote-54, Checkmate 238 were released, where sort of the surgery-centric treatment model shifted to now an immunocentric treatment model. And today everything is essentially about immunotherapy and applying that concept for treating melanoma. So what does that mean, immunotherapy-centric treatment model? Well, in this new world that we live in, what it means is that we want to perform the fewest possible lymph node dissections while also achieving regional disease control. And also we want to select high-risk patients for adjuvant therapy. And when you think about that, you might wonder, like, what's the role of the sentinel lymph node biopsy in this new world of immunocentric treatment? The sentinel lymph node biopsy would, in this new model, serve as a prognostic test that would tell you something about your risk of having a recurrence, and it would also function as a therapeutic procedure, specifically in sentinel lymph node positive patients. Because if you do have a positive metastatic sentinel lymph node, the sentinel lymph node biopsy will reduce the likelihood of an in-basin relapse by greater than 80%. So therefore, the sentinel lymph node biopsy for positive patients, for those patients who have a positive node, is a very useful procedure because it will provide that regional disease control. It will provide patients with access to adjuvant therapy. and it will provide the patient with knowledge of a favorable risk-benefit ratio when it comes to treatment. Whereas when you get the sentinel lymph node taken out and the lymph node is negative, then you don't really have a therapeutic benefit from this procedure. So it's a very useful procedure, sentinel lymph node biopsy, but if we if we select patients the way we're doing it right now, based on NCCN guidelines, what we will find is that only 20% of patients will have a positive sentinel node, will benefit from the procedure, and 80% will have a negative sentinel node, and patients won't really benefit from that procedure in a therapeutic way. And, there won't be any therapeutic benefit for these patients. And so what we were wondering about is, could we do a better job selecting patients for this procedure so that we enrich our cohort of patients that we give this procedure to for patients who actually have a positive sentinel node, because these patients will benefit from this procedure. And is there a way to sort of like filter out the patients who are so low risk that they can safely forego the this procedure, the sentinel lymph node biopsy? And that's basically what the MelaNodal Predict is all about, finding those patients that benefit from additional staging, the sentinel lymph node biopsy.
Thank you for that review. That's imperative in understanding the benefit of the test. Dr. Nousari, can you share with us your perspective on the melanoma space and perhaps the energy around this new assay among you and your colleagues?
Absolutely. I will start with what a dermatopathology report entitled when it comes to melanoma. We have moved over decades from just being a confirmatory diagnostic report to include attributes, histologic attributes, being now the majority in a report that act as a predictors for survival, predictor for sentinel lymph node, and eventually more specific therapeutic interventions. So as we all know, and we're familiar with the College of American Pathology report, the vast majority of the attributes that is mentioned in a report are, they deal with predictors. So that is important because this is our background. And as part of improving in a more tailored fashion with a rationale at levels that are not visible with the traditional histology, these predictor assays play a very important role in the prognosis of this patient. So this assay, in summary, just add in a more advanced and accurate way predictors that we have been using in a classic traditional histopathology.
That's a perfect segue into Dr. Meves talking about his process in helping with the discovery and design of the assay, as it does combine the advancements in molecular testing with gene expression profiling with the understood and standard of care clinicopathologic features. So Dr. Meves, walk us through that process.
The discovery process, right? So this is actually something that I started a long time ago already. It's kind of scary sometimes how quick the time passes. So I actually, in fact, did a postdoc at the Max Planck Institute in Munich with this wonderful person that's depicted here on this slide. He's the director of molecular medicine at the Max Planck Institute in Munich, and he is a person that studied cell adhesions his entire life. Cell adhesions are these miraculous little structures that cells use to kind of attach to the matrix and to inform themselves about the matrix. And these structures, these adhesions or focal adhesions, are really signaling machines. They contain, countless proteins, all known to be involved in skin cancer. And some are depicted here on the slide. For example, RAS family proteins, kinases, integrins, and other sort of well-known proteins known to promote cancer. And so after I came back from my postdoc, I pursued this hypothesis that, maybe perturbed signaling from these focal adhesions is what truly characterizes transformed melanocytes. And that this perturbed signaling would then induce a gene expression program aimed at remodeling the extracellular matrix, and specifically turning the extracellular matrix into sort of like a stiff, hard environment that promotes cell survival, invasion, immune evasion, and metastasis. And so we kind of set out to prove that idea. And so we started in sort of like an unbiased fashion by conducting RNA sequencing of melanoma diagnostic biopsy tissue. And that was already done 10 years ago. And yeah, we looked at the genes that we found to be significantly regulated between melanoma and benign precursor lesions. And then we filtered out about a set of 200 candidate genes that we then quantified by a method that is much more applicable to patient care, which is a quantitative PCR. And we focused on this outcome of interest, sentinel lymph node biopsy sentinel lymph node metastasis. That was sort of the outcome of interest that we pursued right from the beginning. And this is a table from this beautiful paper that we published in 2020 that summarizes these 194 candidate molecular predictors that we quantified across the various diagnostic biopsy tissues that we work with. And I'm just showing you this because you might recognize a couple of them. PRAME, for example, is a gene that we quantified that many people talk about. But we also looked at these integrin adhesion receptors that the cells use to attach themselves to the matrix and inform themselves about the matrix. We looked at P16, CDKN2A, and Ki67, osteopontin, SBP1, which is sort of like famously upregulated in transformed melanocytes, and then also at things like PD1, PDL1. And so a big, long list of genes. And sort of as a benchmark for the predictive performance of our genes, we then use these 15 clinical path predictors that are depicted on this slide, including breast cell thickness, mitotic rate, Clark level, tumor infiltrating lymphocytes, and so on. And then we kind of set out to develop a model to predict melanoma nodal dissemination. Or in other words, we did not want to just generate a generic prognostic test, okay? We did not want to just generate something where we said, okay, you're high risk, you're low risk for metastasis or something like that. But we wanted to design a test that is actionable. And so we focused on this idea of predicting melanoma nodal dissemination. And the way we did that for the model that we later called the CPGP model is depicted here. So the first thing that we did is we put together what we call an intended use cohort, meaning we included patients that would also be tested in real life later after the development of this model. And so we put together a cohort of 754 sentinel lymph node biopsy eligible patients seen at Mayo Clinic. We determined the expression of our candidate genes in the diagnostic biopsy tissue. So specifically, for example, we did not use samples of white local excision tissue, any leftover tissue. We went for the diagnostic biopsy tissue. We thought that was important because we wanted to have the highest quality tissue, and we wanted to make sure that we also, for the development, we used tissue that would also later be used in real clinical care. So we got that tissue. We determined the gene expression in that tissue, the 200 genes I talked about. We obtained the clinical path data. We obtained the sentinel lymph node biopsy data. And then we applied repeated cross-validation schemes to build 3 different types of models. The first type of model that we built was a type of a model that only contained clinical path variables. So meaning variables that we use today to assess risk, like patient age, breast cell thickness, all the types of beautiful predictors that Dr. Nousari talked about that go into the path report today. So first type of models that we built were those types of models that just used basically standard of care sort of variables. And then the second type of model we built were models that were exclusively based on gene expression input. So only gene expression variables, no clinical path predictors. And lastly, we built models that considered both clinical path and gene expression variables. And the best performing of these so-called CPGEP models contain 2 clinical path variables, namely patient age at diagnosis and breast cell thickness, and 8 genes in a gene expression model. And that model, the CPGEP model that I just described, that's what is now called MelaNodal Predict. And that's the model that we set out to extensively validate. And one important observation that we made that I thought was sort of very interesting for me is that we found that the best gene expression models did not significantly outperform the best clinical path benchmark model. So if you only took gene expression and you created the best model and you compared that to the best model you could create from the clinical path variables that we have already available today, basically, the gene expression model didn't really outperform the best sort of benchmark model. It was only when we combined CP variables, so the predictors that we have today, and we combined those predictors with gene expression predictors that we could sort of build models that would improve on the standard of care. So basically, what I'm trying to say is that what we needed to do is to build an integrated model of clinical path variables and gene expression variables to come up with models that improved on the standard of care. So we believe that this is a very important point, because if you don't develop your model as a CPGEP model, but as a pure gene expression model, but then combine it with clinical path variables later in a second step, the information contained in your gene expression model might just be redundant to what is already available as standard of care information. And therefore, your gene expression model might not actually outperform the standard of care. So it's a very important point that I wanted to highlight. And then another point I wanted to highlight is that sometimes when I talk about this gene expression profile or approach to CPGEP, people will say, oh, these genes and these gene expression profiles, they're sort of like all random and they do not overlap with known genes or genes that are known to drive melanomagenesis. But that's actually not true. I just wanted to highlight that the genes in the CPGEP model have all been shown to mechanistically to drive melanoma metastasis in preclinical studies. And these studies were not conducted by anybody. They were conducted by some of the most renowned melanoma experts like Minard Harlan and Reinhard Dummer, and like really, really experienced people. Yeah, so that's my little summary of how we developed the CPGEP test.
Great. Sounds rigorous. And what I heard was a clear intended use of the test included in replicable studies for the eligible NCCN eligible patients for sentinel lymph node biopsy, real world melanoma populations in your studies.
Yeah, so you might ask, like, for example, what's the advantage of working at a place like Mayo Clinic, right? Why is it a good place to develop a test like that? And to me, the advantage here was that I had a very competent, very senior, very unrelenting, very tough statistician that from day one kind of told me that if I want to develop something for patient care, I have to develop on an intended use cohort. You know, I cannot just go to the tissue archive and take any type of tissue out there and put some random assortment of samples together and then just generate a classifier. It has to be done properly. And so I credit, these people here at Mayo for kind of guiding me and kind of telling me what to do. And I think that's the beauty of a place like Mayo Clinic, that you have access to these people.
Exactly, and the test being developed at Mayo Clinic is very credible and respected institution. Dr. Nousari, can you add some color around the clinicopathologic features and your expertise as a dermatopathologist, and what those features mean and why they're important in melanoma?
Yes, absolutely. So going back to the practical, everyday perspective and approach in the relationship between dermatopathology and practicing dermatologists or surgeons, oncologic surgeons. Pathology has moved from just being a mere diagnostic tool to incorporate information for prognosis and even therapy, with the idea to design a more selective and a specific and thus more effective and safer therapy. So pathology nowadays include in many disorders and with more advances in neoplastic disorders, this information. So this assay is nothing more than a reinforcement of where we're standing in medicine nowadays when it comes to pathology. So incorporation of predictors for staging, either local, regional, or distant, and therapy is part of our current pathology approach. So there's something practical that is, we got questioned from practicing dermatologists and other physicians involved in the management of melanoma is, okay, we move from what this standard phrase that we like to use during our education, it's important, the clinical pathologic correlation, to the point that we say it sometimes without even thinking much. It is true, it's valid, and it's always going to be like that. That's irreplaceable. As Dr. Meves showed, that the value of combining clinical path with GEP, it's when you get the best information. But so we add clinical pathologic and molecular genetic correlation. But there is a distinction when it comes to melanoma in a practical question, especially when we're not that familiar with this terminology. One aspect is the molecular genetic correlation for diagnosis, and another aspect is the molecular genetic information for predictors. So this is important. This is an important distinction. The molecular genetic and other ancillary testing in the pathology report, when it comes specifically about melanoma, may include two aspects. One is confirmation of diagnosis in challenging cases, but this is a different view. This is like improving the other attributes that we mentioned for prognosis. Prognosis for regional disease like sentinel and lymph node, and eventually survival. So this is a very important distinction that we have to make when it comes to the report. So, and this is something that is, it has to be incorporated in our mind in light of the current practice of medicine. So we're becoming more accurate, more selective, not only just for the diagnosis, but for predicting disease, especially in life-threatening disease like melanoma, where there is, it's as we know, immunotherapy, it's perhaps the epitome of a tumor in which immunotherapy has been developed.
Yeah, I also wanted to contribute like a little point from the point of view of the lab person, because I did a postdoc, I did a lot of techniques, and what I can say is that, or what probably a lot of people know, and Dr. Nousari probably can talk to that as well, is that, you know, it's sometimes very difficult to quantify something on an image or on a slide, right? There's some of these clinical path variables that might in theory be great, like angiolymphatic invasion, but they're like complex sort of figures that are very difficult to quantify, and you need, you know, probably interpretation varies from pathologist to pathologist. So there's that problem of quantification of some of these histopath, clinical path variables. And the beauty of gene expression by quantitative PCR is that in the end you get a number. You know, you take the tissue and you get like something that's already quantified for you. And that makes it very reproducible and very quantitative. And I think that's one big advantage of gene expression profiling is that you can standardize it extremely well. You'll get the same results in the United States or in Germany or in Sydney, irrespective of the training of the pathologist. You can very much standardize it. And then the beauty of the CpG-EP model Melanoma Predict is that the clinical path variables that we use are also very objective, like patient age. There's no doubt about that, right? And then breast thickness is something that you can quantify really well, I think. So I think it's a very sort of standardizable, reproducible type of a model. And I think that's one of the strengths of this model.
Right, and you both have mentioned the importance of including clinicopathologic features as they're standardized and they're very familiar and trained on for decades past. And there have been attempts and successful attempts at combining just clinicopathologic features in nomograms in order to predict or prognosticate melanoma. Can you speak to how the free nomograms relate to or compared to MelaNodal Predict?
Yeah, so as to begin with, I would like to repeat what I said previously, is that we benchmarked our CpG-EP model to the best clinical path model that we could create based on our own data. Okay, so that's basically the nomogram that we created for ourselves based on CP variables that would perform the best in our development cohort, and that was our benchmark. And that we compared to the CpG-EP model then, and we were checking, does the gene expression profile component add anything to that benchmark that we already have? So we already had that in our paper as sort of like a very sort of rigorous benchmark. But then, of course, as another exercise, we then also did not just use our own internally developed best clinical path model and compared it to the CpG-EP model. We also took, for example, the MSKCC nomogram and took that as a benchmark and compared that to the CpG-EP model. And we found that the CpG-EP model outperforms the SKCC nomogram that many people might have used in the past. And then we did the same exercise for the Melanoma Institute of Australia nomogram, and we could show that we could outperform that as well. And that's all published in the Journal of a JCO Precision Oncology journal. So in 2020, so you can look that up there. Yeah, so we went through that exercise of benchmarking our gene expression model to the best available clinical path models to show that the gene expression profile component actually adds something to what we're doing today, and to show the value of the CpG-EP model. So yeah, that's published, and yeah, we've done that from the very beginning, which also goes back to the strong statistical support that we had and the strong sort of oversight and quality of the development of the test that I was able to sort of organize.
That's great to hear. And knowing that that is part of the body of evidence is important for all the folks that are really familiar with the nomograms and use them on a daily basis to help their patients. It's important to see how they compare and how GEP adds a molecular benefit there. And that was considered through the development and the design of the assay. Dr. Nousari, can you talk about data and body of evidence and what you look for, or what might be the ideal between you and your colleagues in using an assay, and what is important to have to support a test clinically?
I think if I'm allowed to go back a little bit and comment what Dr. Meves mentioned about why this is this tool that we have with melanoma adds more accuracy to what we're trying to achieve with the standard dermatopathology template for melanoma. Even what we're trying to do in dermatopathology is try to extrapolate what we see in affection to what's going on at molecular and genetic level. So this test allows us to, for the first time, to have an open road, direct road to what we're trying to achieve with dermatopathology. So Dr. Meves mentioned very accurately that there is a tremendous intra and inter-individual variability when it comes to diagnostic and interpretation of attributes. That eventually, with artificial intelligence, that can be minimized. But however, what we evaluate under the light microscope, it's a 4-micron section of an entire universe of a biopsy, which is represent also not perhaps whatever the lesion is in total. So we're trying to minimize with a 4-micron section the universe of what's going on at genetic and molecular level. So this is a direct road, more that currently we have to what we're trying to achieve under the microscope. So that's why the beauty of incorporating this, which makes sense if you think about it. So think about, again, and that's what we're trying when I explain to my colleagues in the practice of dermatology, group. It's like, remember, what we do with under the light microscope is a 4-micron section, perhaps a few of them, but there's still microns of the entire biopsy. So what we're trying to achieve is a more accurate way to predict. And by explaining this way, I think that it doesn't take much to convince, dermatology or surgical oncologists the value of this assay, which is nothing more what we were trying to achieve in melanoma, since melanoma has been discussed.
So how did that influence how you and the team went about designing the data behind the assay, as far as protocol, study design, and what your primary outcomes were going to be?
What do you mean?
So in the discussion relating to building on the design and the development of the assay, how did you posture the protocol design, and how did you guys go about designing the data that would be needed in order to reach standard of care, reach clinicians, and be reliable in the field?
So I think we followed like what common sense would dictate you to do. So you develop a model, and then the first study that you do is you try to reproduce what you did in a different set of samples, right? So you do sort of like another retrospective approach. In our case, we went to other universities in the United States and got their samples and tested them, and we looked, can we reproduce, our performance in an independent set of samples? And then we did that in Europe, and then we did that in 7 countries, and we had 12 publications and 27 global academic partners, and in the end we tested more than 4,700 samples to kind of convince ourselves that this test is reproducible, is performing well, and all that kind of stuff. And actually, I have some slides on that as well. I can show you that. One sec. Yeah, so just wanted to highlight this one study that was recently published. It's a noteworthy study, I think. It was published in 2023, and it was the first truly prospective multi-center study on CPGP. Okay, so why do you need to do a prospective study for this type of a test, right? Why not just go to the next archive and run the next couple of samples and then do the next retrospective thing? Well, the reason is that there's always some caveats that you have to deal with when you go to the tissue archive and test some samples. For example, the tissue that you might get out of your archive might be old, like several years old, right? And now you're extracting the RNA, and you don't know what the process of putting that tissue into the archive, and it's sitting there for a prolonged period of time. So you don't know what it really did to the RNA quality, for example. Maybe somebody else came along and did 5 other studies on that specimen before you, and now the block is a little bit depleted. You don't get a representative section and stuff like that. So there's lots of little caveats like this that you can all sort of like exclude when you just conduct a prospective study, and everything is under your own control, and you can make sure you get the tissue right after diagnosis, and then you run the profile, with that type of tissue. Nobody else took the block to do anything else. So therefore, prospective validation is very important. And so the first truly prospective multi-center study on CPG-P MelaNodal Predict came from the Netherlands, 2023. 260 patients were included in these 4 centers depicted on the slide. So you can see one was Erasmus Medical Center, a very famous medical center in the Netherlands, and Rotterdam. There was a center in The Hague, Maastricht, and in Zwolle. So 4 centers, 260 patients. And you can see for the results here, was pretty amazing to me. You can see that for T1, T2 melanoma patients, more than 50% of sentinel lymph node biopsy procedures could have been avoided based on MelaNodal Predict results, while also maintaining oncologic safety with a very high negative predictive value of greater than 95%. So that was really exciting. But of course, people in the United States want to see data from US patients. And so to that end, there's a big multi-center trial ongoing here in the United States called Merlin 001, which is conducted at reputable cancer centers shown on this slide, including, for example, us, Mayo Clinic here, and Moffitt Cancer Center, Memorial Sloan Kettering, other centers. And the goal for this study is to recruit about 1,600 to 1,800 patients. And as you can see, as of March 13th, 2024, we have almost reached target accrual, and hopefully some results become available later this year. And so I'm certainly super interested in learning about the results, and so is the NCCN. You can see here that the Merlin 001 trial got a nice shout out from the Guidelines Committee in their last melanoma update from January. And so we're all waiting for that prospective data. And like I told you before, it's going to be very good data, lots of patients. And yeah, we're hoping for great results. So
that is certainly exciting. It's always a nice inertia when you hear NCCN all abuzz at the AAD, the big dermatology conference, about upcoming prospective data readouts from different folks that are really moving the needle in melanoma and in cancer. So that is really exciting. So what I heard was the body of evidence is sound, it's robust, there's retrospective analysis, there's prospective interventional data. It's recognized as an IVD in the EU with 9 different countries included in the studies, with cohorts in the US, with reputable US academic centers. So it is a really nice body of evidence behind this assay that's coming to the market.
Yeah, there's amazing people also participating in the study. Vernon Zondag from Moffitt is a famous surgical oncologist, sort of leading the study. And then our own very wonderful Tina Heiken here is the Mayo principal investigator for the study here. So really excellent people working on that.
What I can share is the opinion of my colleagues, in the community about this particular assay. It's with familiarity about the utility, the design of this assay, explore many genes with a rationale about cell migration and adhesion. So from the beginning, the design, it was directed to what we're looking for. It was not a random, because that's the idea that we have for the ones that we are familiar with molecular testing and genetic testing, but we're not experts. So we read articles about random genes and mutation, and difficult to interpret even in articles. This has been, in a simple way, designed from the beginning to this goal, narrowing down to genes that are proven repeatedly to be involved, but starting with a broader pool of genes. And that's one of the main advantages and pluses regarding this assay. And of course, ultimately, after there's no, doesn't take a lot of convincing about the utility from a number of reasons, because it makes sense, because they're approved, there are articles, there are scientific background, they are reputable institutions, etc., etc. Ultimately comes to, in the practical daily dermatopathology environment and interaction with the clinician, it's three main questions. Is, okay, now makes sense, I understand, but I'm still have this fear for this complex, I don't want to interpret complex results. And I think the simplicity also, when it comes to high and low risk, eliminating the intermediate gray zone that many tests we have in medicine, putting us in a difficult situation after convincing a patient, etc., and colleagues to do the test and coming indeterminate. That is a very challenging and frustrating situation. So that is one of the pluses when it comes to the practical daily interaction of Dermpath and clinician, is that report they're going to come. It's going to be complex. What I'm going to do with that? So, and of course, the two more generic questions to any kind of test, and specifically when it comes to melanoma, is turnaround time and cost. But the first question is being, okay, this is going to be one of these lengthy reports that at the end it's going to be, we don't know what to do. After going through the ordeal of convincing teams and convincing. So I think that has been a plus, and I have no doubt that this is going to expand and become an important part of our daily practice when it comes to melanoma.
Yeah, we didn't want to provide people or providers or physicians with sort of results that they then have to interpret for themselves. You know, like we wanted to give them clear results. Low risk, you go ahead with the or you can forgo the sentinel lymph node biopsy, or high risk, you should go ahead with that procedure. So that's very unequivocal. The other thing I wanted to say is that a test that predicts sentinel lymph node status, of course, also has prognostic information or value, right? So there is prognostic information also that you get by running the MelaNodal Predict test, because people who are low risk not only can forgo the sentinel lymph node biopsy, but also have a spectacularly high relapse-free survival rate. Whereas people who are high risk should get the procedure done, the sentinel lymph node biopsy, but then also have, as it would make sense, a much lower relapse-free survival rate. And that's another aspect of the test that we might not have enough time to discuss, but yeah, you also get that prognostic information.
Exactly. You'll hear predictive and prognostic being used to describe this assay. But I'm really glad you all jumped onto the resulting discussion, as you said, it was designed to be very simple. And the benefit is that through Dermpath Diagnostics, there's opportunity to have any sort of discussion or peer-to-peer interaction with experts like Dr. Nousari, who are specialty trained within that practice and within Quest. So that's another added value to be able to get some feedback there from the experts. I want to thank both of you for your time and expertise here and sharing with us the benefit of MelaNodal Predict in caring for the melanoma patient and how it affects change clinically. We're excited to see the data that's read out this summer as well. And thank you all for being with us on this webinar, and we hope to see you soon. Thank you again.
Thank you.
Thank you.